What should I do now? She still has 2 years of growth remaining.
One of the things I like to highlight that I will preserve the ulnar distal growth plate. If ulnar distal growth plate is there, we can avoid a progressive ulnar shortening. What is happening is that the ulna is not growing. The almost length of the distal ulna is gone. So if it is ulna is there, radius and ulna would be growing equally. If the distal ulna is not growing, it is bound to happen with recurrent deformity. So whenever we need to address this, we used to follow all the important classification like a Masada classification, and it's very popular in Japan. Unfortunately, our teachers used to teach very greatly type 1, 2A, 2B, 3, but most of us fail to see his follow particle. The follow particle is that I think everybody should read 2007 JVGS. The name is called Akin. Akin. Few of the people can admit their own mistakes. I am not saying Masada's mistake, but Masada has said the lengthening is not having any role of the functional improvement or in distal ulnar osteochondroma. I think we all should read the article, and it's very important and very nicely written. So I'm not telling I used to do the lengthening a lot on the ulna before that also, but now we become more and more conservative on distal radial ulnar flaps. So our approach is there. I generally do, if radial head is not dislocated, I just remove the osteochondroma. If it is subluxated or dislocated, if it is subluxated and dislocated, it's causing the functional problem, I do a temporal ulnar lengthening, but it doesn't improve the function. And the third, if it is adult and radial head is dislocated, then if it is causing painful, then remove. That's my approach.
So what will we do for her heart now, sir? So she still got 2 years of minimum growth rate remaining.
The child will require the minimum one lengthening, and it will require about, we can do about not at this stage, but
we are asking what can we do at this stage?
At this stage, if it's very difficult to do about radial stapling. If it is that bowing is there, we do about epiphyseal disease on that, it will prevent the bowing. But the shortening we can't do about that. We need to do weight. Once it has been little older, we can do over lengthen. For preventing this, I generally, if it is growth plate is not there, I do about over lengthen. 1 to 1.5 centimeter over length, even more than that also.
Okay, so this is one new idea that I have not think about it. So the growth plate of distal radius is still active. So I could have done some sort of epiphysiodesis of the distal end of the radius.
Yeah.
Maybe a kind of hemi-epiphysiodesis also, so the radius can rise a little bit also. So that could be one reason. The reason why I actually become satisfied, because though the child has 2 years of growth remaining, but we all know that the 75% growth of the ulna comes from the proximal end. So not from the
Distal end. Distal end. Always distal end. Distal end.
So it was reverse, I think.
Always distal. Shoulder and the wrist. Always. Opposite.
So what can we do now, sir? Now,
You can do about radial osteotomy. You can combine two things.
she is 14 years of age right now.
Correct. You can do about that combination of the radial osteotomy and ulnar lengthening. So this is mature. We can get it the correct element.
Okay. So corrective osteotomy, right? So you advocate any kind of shortening for the radius?
It is associated with, or if it is do acute, it will be associated with higher chances of compartment. But yes, it is described also, both.
Because one question is always kept in my mind whenever we treat Montagia, fracture dislocation, right? So every time we go for the ulna. So we go for the ulnar lengthening and so the radius can come down. So I just wondering, for the treatment of a Montagia fracture, can we just simply shorten the radius instead of going for ulna?
But in Montagia, it will not solve the problem. Here, Montagia, there are two issues, angulation and shortening. So only doing about radial shortening, we are not going to address it. So we need to correct the angulation as well as the shortening. Here, If it is radial head is not dislocated, you can get away with only doing short.
Okay. So that will be my cases to be discussed. You want to show some more on hereditary multiple access diseases?
This is okay.
In case of ulnar osteochondrosis, why will we start the treatment? If the radial head is still dislocated, what will we do?
So at the time of diagnosis or after lengthening? After lengthening. After lengthening. So it is written in many journals that whenever you go for lengthening of the ulna alone, there is a chance of the radial head can gradually go back to its normal position. But chances are not less than 50%. So it may not correct that. So once you go for, after completion of the growth of the ulna, then definitely you can go for the radial head. Now, if you can go for excision when the child is near almost adult or something like that. In a 10 years or 12 years, it is not advocate to go for the radial. He said that we have lengthened the ulna, but the radial is still remains usually. It has not come back to its normal position. So he's asking what can we do at that point.
So, just two cases here. Foramen in multiple hereditary exostosis. So one is, what is obvious is ulnar shortening. And this is the Masada's classification, like 1, 2 and 3, which Hitesh spoke about. And this becomes type 1. There is a osteochondroma lower in the ulna with bending of the radius. The state of the art treatment today, if you get this, excise only the osteochondroma, preserving the radial, preserving the ulnar fibers. And if you do it early, there's a from Texas, Scottish Rite Hospital. Most of the later deformities can be prevented if it is done early. Now this child is already 11-year-old, and it's not just ulnar shortening, there is also radial deformity. And this child was symptomatic, so we decided to operate her. And what was done is to, again using simple external fixator, you do place wires in radius in this fashion, and then wires in ulna. 4 wires in radius and 4 in ulna, and then in radial you will do a osteotomy at Cora and get all wires parallel to each other and fix them in the next place. And in ulna will put external fixator at the same time over a K wire and then run the ulna. And at the same time excise the osteochondroma, keeping the ulnar epiphysis intact. And then, it's likely that you will not have a return in this patient. So in this patient, this is what we did. You can see that ulnar osteochondroma we have excised. We don't see it anywhere. The radius has been corrected and then fixed with the wire, and then we remove the fixator. And ulnar we are lengthening, and you over lengthen the ulna. You don't get it normally. You don't get it exactly at zero station. You over lengthen the ulnar so that it supports the carpus, and then that's the time you remove the fixator. By this time the patient is already 20-year-old and it's maintained very well. This is a longer follow. This is followed at maturity at 15 years, and you can see that the chromosopilations are good. Wrist is maintained, and the child has done. This is problem number 1. The problem number 2 somebody was talking about is ulnar shortening with radial head dislocation. And this patient, somebody had excised the lower end of ulna, and hence there was a problem. You can also see the upper extension of the elbow. So this radial dislocation is symptomatic, and every time the child was having pain in the aspects of the elbow joint. So how do you treat this? So this is type 2B. Okay, and the way to treat this is a little tricky. And what I would do is lengthen the ulna so that you can get it at the level of lower end of radius. And at that time, connect lower end radius to ulna to fix it up. And then continue to lengthen the ulna, and when you continue to lengthen the ulna, the radial head will come at the level of the elbow joint. And if it's stable, you can leave it at that. If it's unstable, you can do a small opening and do actual open reduction of the radial head, because now it has come at the level. So this is how we treat it. So this is patient I will show you how we treat it. So we put wires in ulna, lower end and upper end, our intramedullary wire and a fixator. There is also fixator in radius which is not connected to ulna at present. And then you lengthen the ulna, and once ulna comes at level, you continue to over lengthen it, and once you over lengthen it, you connect radius to ulna through this cross clamps. Is this visible to everybody? So there are wires in lower radius which you are connecting to ulnar fixator with help of bend rods. And then you continue to lengthen ulna and radial head, fortunately in this child without any open surgery came to a level. And that's the time we remove the fixator, and you can see a longer follow. She's got good progression, supination, elbow movements, and her radial head is still inside. Very good work. You can see I have over lengthening ulna is the key to stability of respiration. So these were the two cases I have to discuss. Any questions? Right. Just to commit at +2 station. So we don't want ulna to be prominent, but at the same time, we want it to stabilize the wrist to be neutral, which is important. If there is undercorrection, then it is not functional. Yeah. So what I've seen is when you overcorrect the ulna, the radial head gets weak. The pressure over the radial head goes up. And once you over-lengthen the ulna. So under-lengthen the ulna, always proprioception movement will not be somewhere there will be impeachment. So this decompresses the radial joint. So this completes the multiple hereditary associations. We can
you put another
okay.
Radial head is dislocated. So can we give blue cross KOR, so blue KOR from radius to ulna for distraction of the radius at the same time?
It can be done, but there are very dangerous structures in front. If you pass a wire from radius to ulna to radius or radius to ulna, the problem is that it may go through your medial nerve or some of the muscles or vessels. It's better to fix them outside than fixing them from within. If you are distracting, it is better to fix it from outside. Because when you are passing wire from radius to ulna, it may go through some nerve or vessel, or it may go through some of the tendons, and we don't want that. You fix the radius to ulna? But we just maintain the radial length in Galeazzi fracture, and we don't take a like syndosmotic fixation is only for adults. We don't do it in children.
I want to make one point. The Galeazzi fracture dislocation in child is different than adult. You know that if you...
My point is, in case of Galeazzi fracture dislocation in adult, we used to move cable from ulna to radius.
Correct.
So no chance of, or minimum chance of reaching your final sense. So
yeah,
in that case,
but
pediatric
I have kids, I think, but the biggest problem in the kids putting from ulnar to radius, with simple wire, also ulnar pulses will have irreversible changes. So if it is possible, please avoid it. Please avoid it. With simple wire, I think distal ulnar pulses is such a sensitive, putting out one wire, I think Carol will also agree, the distal ulnar is very dangerous, even for the fracture also. Please remember, it's simple wire can damage the irreversible changes for the ulnar. So if it is possible, avoid it. That's a very important message actually there. And kids' Galeazzi is different than the adult Galeazzi. In an adult Galeazzi always require fixation. The kids, most of 90% ignore. Even though in the adolescent. So it's, we need not to do about any fixation for the child Galeazzi. Yeah, this is a 13-year-old girl, have the left side deformity. Okay. So, what is the diagnosis? Very straightforward, or it's difficult? Anybody wants to say anything on the diagnosis? On the Madeline deformity. So, how many of us have seen Madeline deformity? Very rare. Okay. Unilateral or bilateral? Bilateral, both. Okay. So what is associated with Madeline? Very, very common. It's very weakest ligaments. Okay. But would you examine the upper limb and lower limb together? It's very, very common to have a Lally-Willy disease, dysostosis. And SOX gene is very, very common. Okay, so always examine, it's very common. The mesomelic skeletal dysplasia, always, whenever you will have a chance to have the Madeline deformity, examine the tibia and fibula, see the length of the tibia and fibula, see the bilateral symmetrical or not. Okay. Okay, what should we do? Okay, sorry, X-ray. April 11 X-ray. Yes. What should we do with the Madeline deformity? 13 years. Growth remaining, yes. Yes. No osteotomy, sir. Yes. Yeah. Okay. Anybody like to leave? Anybody like to leave? What will happen generally if you see the Madeline deformity? What will happen if you leave Madeline deformity? Again, the literature in Madeline is less. Okay, again, the literature in Madeline is less, but there are the three types of deformities described. Madeline, reverse Madeline, and Chevron deformity. But then what will happen? Generally we see, and as a surgeon, radial dislocation will jump and reduce the radial dislocation. For my mind, if it is causing the supination and pronation restricted, if it is causing functional problem, we need to do that. Again, Madeline deformity, if it is going to cause a pain, then I will operate. I do not give any treatment because I have seen many Lally-Willy dysplasia, bilateral symmetrical, doesn't require, all the Madeline don't require the treatment. All the Madeline don't require treatment. Believe that. It's not all the Madeline require the treatment. See, he is not operated single Madeline. Thoroughly the role model is saying that's. Yes, then you need to. That terminal restriction is different, but yes, if it is pain, yes, we need to. I do agree in that, but I like to focus not only on X-ray and treatment, surgical treatment. That's one of the important points I like to highlight there. Yes, if they are coming for a cosmetic, that's why it's important either unilateral or bilateral, whether the dorsiflexion, plantarflexion, and supination, pronation is restricted or not, because many of time it's a long-standing deformity. When you are going to correct the cosmetic, you should not lose the function. That is also a very important point for the patient, because sometimes dominant or non-dominant hand, what they are going to use, and it's very common in female, not very common in the male. So when they are when they come for the deformity, we need to say the deformity. Yes, do we do MRI for Wicker's ligament? No. Sir? No, we don't do the MRI, yes, but is been done and say, as the growth remaining, we do about the water approach and do the facial bar excision like that. We need to do the Wicker's ligament, excise the bar and put the interposition fat. The same has been done for this child. And if the growth remaining is there, this will be sufficient. This will be sufficient because at this child also it was sufficient, and final pole of the pain also disappear and she is now mature. She is not having any symptoms. So all the don't, it's correct to do the osteotomy, there is nothing wrong with that, but that may not be necessary. May not be necessary. Okay, the second case, it's NF1, it's deformity. And this child has been treated by the orthopedic surgeon, has got the radius fracture. Initially treated with the plaster, then later it is treated with a wire. And this is the clinical pictures, and this is the radio. Pseudoarthrosis of the radius, but that was post-infected, first This is not. This is NF. So is it the same like the tibia? Is it the same like tibia? Would you like to treat the same like tibia? Tell us what you do in pseudoarthrosis radius. Radius is much more challenging than the much more challenging. Okay, sir. Intramedullary area. No, say 6 years. 6 years. Yes, that is one option. But that is another option. That is, I think it will be taken last resort because the proximal radius is 0 here. So yes, vascular scapular graft, yes, very important. Very recent systematic literature says about vascular graft has got the best result. But being that every surgeon can do the surgery about that, is treated like that, maybe the osteotomy of the ulna, the tricortical graft of the radius in that radius, and we fix with the radius and ulna, both with wire. That's it, 6 weeks. And 3 months, you can see the 4.5 months united. Okay. That's 6 months. That's 1 year. You can see the wire is receding, so it's growing. Okay. So just pay attention to the ulna. You see, just one wire. Nothing has been done. Just ulna. See what happened to ulna? It's damaged. You can see that. That's the message I was giving. It's unintentional. It is not for the doing intentionally to the ulna shortening. It's initially beginning radius was short. But now the ulna is short. Possible. There are multiple theories we can say because it was growing. It was growing. But it might be late fracture. Or it is because of radius. We don't know. Actually, for this particular case we don't know. But she is doing very well function. 8-year follow-up, she recently came. She doesn't want any surgery or anything else. But we kept the both radius, actually the longer. So we kept the both the radius and ulna K wires still. And there is fortunately no other deformity, and she is near maturity. Yeah, it says once is do it quite okay. Yeah, the third case, see, the child has got the distal radius fracture. Somebody has treated, not distal radius, middle third of radius fracture, treated with one single wire, and they developed this. So what is the deformity? Is following that? Yeah. So would you please consider it like first Madeline? Because he is 10, 12 years. I don't like to do the facial bar, but 8 years after, no, he said no. Okay. Yes.
Most programs.
Yes. Please tell me more.
What will work is doing an operation and doing radial lengthening for
Yes. It is very important message is said that the facial bar excision will have not very good prognosis in distal radius. There are two reasons for that. Number of things are locating, and it's a very three-dimensional structure on the facial. Exact locating is very challenging actually, in particular in this. But here with CT scan it was more than 50%. So again it will not be useful. Either way, it doesn't give the good. So you can't do that in 50%. More than 30% you can't do that. Up to 30 it is good, facial bar. But again 30, the results are not good in distal radius. Yes, in distal radius. Distal radius. Femur and tibia is good, not in the distal radius. Okay, as Karan said that we did this is the pronation, supination, we did with the dome osteotomy, shortening, and as well as we did the fusion of the distal ulna, because that radius is also reduced, and it's doing quite well. And this is the last follow-up. 1 year, remove the implant also. The radius is also not growing, ulna is also not growing. So hope that we need to have that in the long run, he will be doing good. Okay, thank you. If it is younger patients, if it is older patients, obviously. Adolescent patients, it's very difficult to hold with wire. It's very difficult. So we'll put it will go back in the same position.
The old guy is 8 years and above.
12 years. 11, 12 years. If less than 10 years, KY is okay. You can use it, but the parents doesn't want to have the long procedure. They want a single shot, with the simple, and this child can go and do the lenses. No, there is no problem with this. Very important option. It's a good option. Will have problem. Yes, it will have problem. Only that because the ulna is straight and radius is big. That's why it is possible.
radial lengthening is can be done single. You don't have to sort of distract them. You can do lengthening, put on graph, and then go play, and then ulnar lengthening is not required. But this must still require more than 2 seconds. But an easier solution is to soften the and correct it. That is also an option. So let's go to the next one.
Thank you so much. Respectively, master's certificate by Professor Anand Goel, sir.
My site is certificate. This is a misnomer. This is not actually the Maya.